Hello, my name is Carolina Ramos, and this is my presentation on current legal and regulatory issues for advanced practice registered nurses. So APRN scope of practice, advanced practice registered nurses, also known as APRNs, have a clear and defined purpose and scope to which they are able to practice with their license. And it is important that this is defined because regardless of whatever state APRN works in, what they went to school for should all be defined into what they're able to practice as, even if a certain state has restrictions. But according to APRN guidelines, APRNs are allowed to assess, diagnose, perform, and supervise. They also order tests, treat, coordinate care, and educate. So APRNs are allowed to do all of those things I have listed within their scope of practice. They are allowed to do this to the full of their ability unless the state they live in says otherwise within their laws. But accredited schools teach APRNs all of these things, and they are educated enough to practice everything that was included. APRN state regulation. Different states have different regulations for APRNs. There are full, reduced, and restricted state practices. Currently, in the United States, we have 29 full practice states, which also includes the city of Washington, D.C. as its own sovereign, 16 reduced restriction states, and 11 restricted practice states. So what does this mean? Full practice states allow APRNs to practice to the fullest of their abilities. So everything that was taught in school, they're able to practice without any restrictions. They can do everything within their scope. They do not have to be supervised or looked after or babysat. Reduced practice means that there is at least one aspect within their scope that an APRN is not allowed to do without a physician overseeing them. So this could just be ordering specific tests or performing specific techniques. It depends on the state. Each state is different and they make their own laws and regulations. Restricted practice means that all care that's provided by the APRN must be overseen by a physician, and the APRNs are not allowed to practice independently in a restricted state, even if it's within their scope of practice and that's what they went to school for. They must be overseen by a physician. A physician must be in agreement with the APRN on what they are allowed to do and what they are not. And ultimately, the physician is responsible for the APRN, even though they are also licensed professionals. Alaska is considered a full practice state. APRNs are allowed to practice in Alaska to the fullest of their ability. The qualifications to be able to be considered a PRN in Alaska is must be a registered nurse, RN, a graduate from an accredited APRN school, pass the national certification, and there is also an extra rule in the application process to become an Alaska APRN. You also have to have a consultation and referral plan in place in your application before it is approved and you are considered an Alaska APRN. What this means is that in the application, the applicant must describe how they practice what their plan will be for consultation and for referrals, and they must also complete a quality assurance plan. The instructions on how to do this are in the actual application process, so that if a nurse is coming from a different state to Alaska, they understand how to complete it. Right now, there is a shortage of healthcare providers in Alaska, ultimately due to the climate, the weather, the landscape, and how far it is from the mainland of the 48 states that are conjoined, since Alaska is between the US and Canada, even though it is a state. Right now, there's about a 22% shortage of providers in Alaska, which is a great deal for providers in that area, which only hurts patients. So on the other hand, Tennessee is a restricted state. So the applicant to become an APRN in Tennessee must be a graduate from an accredited APRN program, as well as being an RN. They must pass the national certification, and they must have a supervisory plan with a physician, not just a collaborative. They must be strictly supervised in the state of Tennessee, and they are called supervisory plans. So this means that they are going to work under a physician. The physician must oversee all aspects of care and sign off on the care that's provided. The physician must be available to the APRN as stated in the supervisor plan at all times, and if not, be at least reachable over phone, email, computer. And this is under Tennessee law. I've added Florida, as I live in Florida, to speak on the differences. It is also a restricted state, but it's a little different from Tennessee. So Florida is a restricted state. You must be an RN, must graduate from an accredited APRN school as well, and pass the national certification. There must be a supervisory plan with the physician. However, in Florida, once the APRN has worked over 3,000 clinical hours, they can be independent under a collaborative plan. So they're not fully independent, but they have more independence and don't have to strictly rely on the physician. Under this collaborative plan, a physician will still oversee things, but they're not as strict, and the APRN can practice without needing the physician to sign off on all their orders. They must have a DEA number, which is the Department of Enforcement Agency for Drugs, Drug Enforcement Agency, and they cannot prescribe Class 2 controlled substances without appropriate psychiatric education and under psychiatrists. So there's still not that much leeway in that aspect, but it does open up and lessens the restrictions. Key legal, regulatory, and credentialing issues. So currently there's no cost regulation for collaborative supervisory agreements with physicians. So there's no set amount of money for these agreements. So pretty much a physician can charge the APRN as much as they want or as little as they want for these agreements, because there's no set cost. There's no law stating how much or how little a physician can charge to be their supervisor. This sets problems because some physicians may charge an outrageous amount, and other physicians might just do it to help someone out. So there needs to be a law or something set in stone for these states that are restricted, but there's not for cost-wise, which can be a hindrance to the starting APRN who usually doesn't have enough money. They're just starting off on their career and trying to learn. Another problem is hospital admission restrictions in non-full practice states. So if the APRN decides to work in the hospital, they're unable to complete admissions without being in agreement by the physician. If the physician doesn't agree with the care plan that the APRN has made, it can be completely thrown out and have to redo it. So this can add to a lot of frustrations for the starting APRN, and which can hinder their confidence and make them go into an imposter mode, feeling like they don't belong. Why did I do this? So there's definitely problems with that instance. Also, not all states require national certification for licenses. So states, for example, New York, California, Kansas, and Indiana do not require a national certification test like other states do. In those states, you can just be a graduate from your school and follow the state laws, and you can be an APRN without having to take a national exam from the for example, the NCLEX for registered nurses. You don't have to do that for those states. So there's no uniformity. There's nothing set in stone for all these states, which really affects the profession as a whole, because some people might not see that profession as serious. Why does everyone else have to take the state exam, the national exam, and these other states don't have to? So there needs to be some type of uniformity. That way any APRN can practice in any state, since we all have the same education from an accredited school. Also, you must have a Drug Enforcement Agency DEA number when prescribing narcotics. So if you are going to practice, let's say in Florida and then in Georgia, you must have a DEA number for each state that you're going to practice in. No one DEA number is the same for your career or for your license. You must have a different number for each state, and also if you're going to work in different buildings, you must have a different DEA for that other building. So things can get a little confusing. There's no uniformity there as well. Regulatory barriers. So some physicians do not want nurse practitioners or APRNs to be independent in those restricted or reduced restriction states. Some physicians state that full practice shouldn't be allowed because APRNs don't have the sufficient knowledge or understanding to not be supervised. I don't agree. I think that the APRN role is not understood by people that think that, physicians that think that. There is a misconception about broadening the APRN scope, which is what a lot of these physicians think that the APRN Association is pushing for, but that is not the case. There's no broadening. They're just trying to have the APRNs actually work to the full extent of their license and what it entails and what was taught. These restrictions don't let an APRN flourish to the best of their ability. So I think that there's a lack of education within the community that thinks that APRNs are just trying to be doctors. That is completely not true. It's a completely different education model and not taught the same. We are collaborators and we are teammates. We are not physicians. And I think that there's just some miscommunication and confusion with these physicians pushing back on not allowing full practice in these restricted states. COVID brought out a lot of deficiencies in the medical profession, a lot of shortages, physicians currently in practice not being able to keep up with the demand, the government having to ask for retired physicians to come back to work, please, because we don't have enough people to care for these sick people from all ages. So that really brought about the shortage that we currently have. And the government actually, during the Trump administration, allowed for full practice in all states as an emergency law for the duration of the pandemic. And this really helped cover the shortages by APRNs being able to prescribe and diagnose and order medications that were needed, especially in primary care and in the hospital. So that actually helped lessen the restrictions. A state that finally understood, well, maybe this isn't the best idea to keep these APRNs restricted. We really need help, and this is really helping, was Massachusetts. So they were a restricted state, but recently in the past year, they passed the legislative law and are now a full practice state since COVID. Progressing to full practice. So California is officially still considered a restricted state, but actually in the year 2020, after the pandemic started, the governor of California, Governor Newsom, passed a law that he is considering for California to become a full practice state. However, it has not been passed yet. The first part of the law of him agreeing to it has been passed. It has to go through legislation, but because of COVID, there's a lot of fallbacks, legislators not meeting within time with so many laws being, as we say, on back order, on backdrop. So legislators not working full-time hours have hurt the law and has delayed implementation. So as of now, the plan for California is that these legislators are actually going to meet at the end of this year and hopefully pass the law that California will now become a full practice state starting in January of 2023 if the law is passed by legislation and then signed in by Governor Newsom. So things are starting to move along. The pandemic has definitely brought out the worst of the medical system, and I think that finally, little by little, states that have resisted are starting to see the light of the good that APRNs can be to the full extent of their licensure. With this law, Governor Newsom would allow California to become full practice if they have 3 years of experience. After that, they are considered full practice APRNs. So not completely full practice until they have 3 years experience, and then after that they have no restrictions. So we are heading towards the right direction. It would be nice if it was full practice from the start, but they have their reservations. At least now the experienced nurses that have had time already would be considered full practice, and the new APRNs will become full practice APRNs after their 3 years. Professionalism. So professionalism for APRNs, similar to as regular RNs, you must be prepared, having resources available for not just for APRNs, but for doctors, medical students. Applications such as EpiCRITs and UpToDate are very useful. These applications have evidence-based practice to back them up. They also have linked actual journal studies that have been proven. If you're looking for a different diagnosis, a differential diagnosis, what medications someone should take for such and such disease, you can rapidly look it up on these applications if you don't have the knowledge at the moment until you gain experience. Obviously, looking professional, appropriate hygiene, maintaining eye contact with the patient, and speaking in a clear and neutral tone so that they don't feel intimidated. If an answer is not known, do not say I don't know. State I will be back and I will get you an answer, and find the appropriate answer from a provider or using one of the applications. Professionalism's RN versus APRN. So when the role is switched from RN to APRN, we're still nurses, we're still registered nurses, but we're now advanced registered nurses. So usually with that entails different attire. So with APRNs, you're going to be usually in professional attire, maybe wearing a lab coat, wearing a suit, or professional slacks, a blouse, versus scrubs. That is what is worn with as a nurse practitioner, unless you work as a registered nurse, unless you work in an administrative position. Appearance, again, maybe hygiene, hair. Usually in a professional setting, the hair can be worn down if it's neatly pulled back out of the face, but it can be down. And with registered nurses, you have to wear your hair up out of your face because you might be dealing with fluids and whatnot. This may not be the case if you're working in a specialty such as the operation room or something like that, but in general, for primary care, usually you're wearing professional attire and your hair can be down. APRNs have higher responsibility because you're now the provider and you are the person in charge, diagnosing, finding out what the problem is and how to fix it instead of just doing what you're told and what is ordered as a registered nurse. So you have more autonomy as an APRN. Both have similarities in upholding care, and obviously the number one rule is patient safety. We always want to keep the patient safe. Transitioning from RN to APRN. So there's a different mindset. The number one rule, of course, is the same within both. The patient is the center of attention. But now, as stated in the previous slide, you now have to think differently. You have to use different critical thinking mechanisms as a provider, finding out what the problem is. Not just finding the problem, how are we going to fix this problem? What do I have to do? If this doesn't work, what else can I do? So things are a little differently. As an RN, you still use critical thinking strategies as an RN, but most of the time you are following orders. It might be difficult starting new as an APRN, just as when the person was just starting new as a registered nurse and they hadn't been a nurse before. It is a new environment, same as the APRN. You're still a registered nurse, but now you're in a different role. So it can be scary transitioning, but just as with anything, experience is key and time will favor and the person will start to get comfortable in their new position. Having a support system helps ease anxiety. Having someone at work, a physician, a coworker, another APRN that might have more experience than you help ease that transition. It is also important for the APRN to pay attention to contracts and what is included. As registered nurses, we're usually given a 3-day-a-week, 12-hour shift, and then here's your wage. If you don't like it, well, we can talk a little bit about your wage, and then that's about it. But as a provider, there's a little bit more in depth. You have to think about malpractice insurance. Is that included? Is your provider now going to pay for it? Whoever your boss is going to be, do you have to get this malpractice insurance yourself? How much is the wage? Is it an hourly wage? Is it a salary wage? And what will your hours look like? Most APRNs, unless they work in a hospital setting, don't work weekends. If you do work in a hospital setting, it's usually 1 week on or 1 week off or just consult. So it's very different and more complex than just a regular registered nurse. You have to think of these things. Are they going to pay for continuing education? Some contracts do. Some contracts are more lucrative and also pay you a bonus if you achieve certain milestones. So it's definitely different. And the APRN that is new must know and be able to differentiate on what contracts are better than others. And it's not just about the money, also about the work environment, which seems more suitable to the person. And knowing that learning never stops, regardless in what position you're in, you will never stop learning. So it is important that the APRN understands that as well. Learning never stops, and you must stay up to date with new clinical findings so that you can give the best practice and the best diagnoses to your patients so that you don't fall behind. And these are my references. This is the first page of references, and this is my second page of references. Thank you so much.